No problem. Thank you for trying. Doesn't look like everybody's here.
Yeah, we'll probably give it one more minute.
All right. I'm going to go ahead and start with roll call. This is good morning. This is the January 19th PEB board meeting, and I'm Kimberly Hendricks, the chair. Sean Parkman.
Here.
Dana Harganani. Kim Harmon.
Here.
Good morning. Saban Martin.
Here.
Good morning. Kate Nass.
Good morning, I'm here.
Oh, good morning.
Good morning.
Mark Perlman. Jeremy Vandehey. Senator Betsy Johnson. And Representative Andrea Salinas.
Good morning, I'm here.
Good morning. Thank you so much for joining us. All right. Mark Perlman, were you there? And then Jeremy Vandehey. Okay.
I think we just have a couple late arrivers, Kimberly, but we do have a quorum.
Okay, perfect. Thank you. All right. So the first order of business is the minutes. If someone had a chance to, well, we've all had a chance to review them, but if somebody'd like to make a motion.
This is Siobhan. I've reviewed the minutes and I will make a motion that we accept the minutes as written.
Thank you. Do we have a second?
This is Sean. I'll second.
Thank you, Sean. Any question, comments about the minutes from December 15th? Okay, so since we're on screen land, let's go ahead and just do a quick vote. Obviously, Sean?
Yes.
Dana hasn't joined us late, correct? Okay. Kim Harmon?
Yes.
And then Siobhan?
Yes.
Kate?
Yes.
Accept the vote. And then Mark? Or Jeremy? Okay. Looks like any opposed to accepting the minutes as written? Thank you. All right, it looks like first up is going to be Nick Albert from Mercer, and it's going to be our annual renewal primer and ASO benchmarking. Good morning, Nick.
Good morning, Kimberly. Michael will also be joining for a part of this. So this is a report that we normally provide in the January timeframe, and it helps set the stage for the upcoming renewal for PEBB. We have already sent out the round one renewal request to all of your carriers, so those are due back this Friday. So we like to sort of set the stage for what we're going to be talking about over the course of the spring. So if we go to the next slide, we'll talk about the renewal goals, guiding principles, and then the timeline that we're going to be working on. Relatively new for this year is a little bit of benchmarking. So for your self-funded plans, Providence and MODA, we are going to benchmark, or we have benchmarked those administrative fees that you pay to Providence and MODA against a database that we have internally for our clients. So we're going to look at how those fees compare to our Mercer benchmarks. And then Michael will step in and do a little bit of clinical program review for both Providence and MODA. Both of them sent some additional data on their clinical programs that they conduct on behalf of PEBB. And so we wanted to basically show those findings to the board, and so you have an idea of what additional services and value both carriers provide. If we go to the slide 4, so 2 slides. Next one, thank you. The guiding principles, so this is nothing new. We developed these, I think, at this point, one to 2 years ago. But essentially, we have the triple aim on top, all the way down to the success measures on the bottom. One thing that has become more prominent and important in the last 6 months or so is that middle section on health equity. So one of OHA's guiding principles is around health equity. That had been established a while ago, but it's become obviously more prominent for us as we think about health equity in the context of making renewal decisions. Next slide. I won't get into these in a lot of detail, but we developed these after the November board retreat. These are our health equity strategic pillars. Michael actually has a follow-up presentation later this morning that he's going to be diving into these a little bit in further detail, and then talking about the next steps associated with each of these. So we wanted to include these for reference in this presentation because, again, think about the context of how we're making renewal decisions. This is obviously one of those contexts that we have to keep in mind. So we included it here, but Michael will talk a little bit more about it later this morning. Next slide. And then finally, just everyone for reference to the renewal timeline for 2022. So this upcoming February meeting will be the first of three or four throughout the spring and early summer, where we talk about the renewals and talk about the upcoming projections for 2022 for the self-funded plans, the administrative fee renewals, Kaiser's fully insured renewal, and all the rest of the carriers. So February 16th is the first meeting where we talk about the round one responses for that. Any questions on the sort of timeline or framework that we're working in? Okay. All right, so the next section, if we flip to slide 8. So what we wanted to do was provide some context for your self-insured administrative fees. So PEBB pays Providence and MODA administrative fees, and in return, obviously, Providence and MODA administer the plan, pay claims, conduct utilization reviews, utilization management, all of the clinical programs that they have in place. All are paid for by the administrative fees. So what we wanted to do was provide some background into those fees and how they compare to some of our other self-insured clients. And essentially what we look at are 2 buckets. Fees come in 2 buckets. The administrative fee is one of those. So that's a fixed cost. It's a per employee per month charge that each of the carriers that we talk about at time of renewal, essentially. The other component are what we consider variable fees. These variable fees are typically charged as a percent of savings. So the best example I could think of is if a member goes to an out-of-network provider, for instance, the plan will often negotiate with that provider to bring the charges from billed amount down to some lower amount. Well, what typically happens is variable fee gets charged as a percent of that savings that they negotiated on your behalf. That's one example of what a variable fee is. There are other, such as the plans do audits. They sometimes do subrogation with different health plans. So there are various components to that. But essentially, what we're trying to do is capture everything that PEBB pays, not just the fixed cost, the PEPM. So next slide, Rose. A little bit more into the variable fees. They are becoming a little bit more prevalent in the market. So, quite frankly, as cost pressures become more apparent in sort of the ASO fees, so the fixed portion of that, what we've noticed nationally is an increase in these variable fee programs and the prevalence of those. So they're essentially, again, not included in the base administrative fee, and they vary based on activity. So one year PEBB could have 10 members go see an out-of-network provider. The next year they could have 5 members. And so, as you can imagine, these sort of fees shift each year, year in and year out, based on actual utilization in the plan. So that's why they're a little bit harder to track and quantify. And quite frankly, they come through usually on the claims wires. So they're not like a separate admin fee or invoice, for instance, that you would pay to Providence or MODA. They're oftentimes in the claims themselves. And so as PEBB funds the self-insured claims, some of these fees may be included within those. They sometimes, they can, but they don't always generate true savings. So especially when the carrier keeps a portion of the savings, oftentimes that percentage is anywhere between 25 to 40% of the savings is kept by the carrier. So we feel like there is some value to these programs, but it's important to keep track of what you're paying. Next slide. So this is a look at the historical administrative fees that you've paid to Providence and MODA. So the bottom, starting from the bottom upwards, the bottom line, that light blue, is the statewide plan. The green line is the choice plan. And then starting in the 2019 plan year is MODA's administrative fee. So MODA was fully insured prior to 2019, and we made that switch to self-insured effective 1/1/2019. So on average, you can see that choice and statewide have increased about 2 to 2.5, 2.4% on average per year. You can see that green line dropped significantly for the 2015 plan year, and that was as a result of the medical RFP, or partially as a result of the medical RFP. The RFP came effective in the 2015 plan year. So you can see the result of that RFP driving down the choice administrative fee. And then since the RFP, it's been slowly climbing back up. And then MODA became effective in 2019, as I said, and MODA's administrative fees are higher than both choice and statewide.
And Nick, this particular graph is just the admin fee, so this one's only the fixed fees, right?
Exactly. Yep,
Okay.
That's exactly right. Okay, slide 11. So Providence has an additional component to their administrative fees called the triple aim incentive. So the triple aim is basically divided into 3 buckets: lower cost, better service, and then better care. So within each of those, there's a certain, it basically splits out to about a third for each of those categories. So it's $5 incentive for lower cost. Essentially, Providence's claims increase needs to be less than Mercer benchmarks. The better service category is actually slightly lower. Better service only accounts for $3.63. For those of you on the board who have been around for a few years, in the 2018 plan year, we actually negotiated with Providence to keep the administrative fees flat for that year, but as a result, they actually lowered the triple aim incentive slightly. So they lowered their better service metric from $5 to $3.63. So that was as a result of some of the negotiation where we preferred to keep the total fee flat instead of increasing. And then finally, better care is essentially performance in disease prevention and care management. So essentially HEDIS metrics that Providence has to meet. So what the graph is essentially saying, so it looks at 2015 onward. The left-hand bar is the blue is the statewide total fee, and then the green right underneath is the triple aim incentive for the statewide plan, and then the pink and dark blue is the choice plan. So the pink is the choice total administrative fee, and then the dark blue right underneath that is the choice triple aim incentive. So you can see that as the fees have increased, the triple aim incentive has actually remained has remained flat and decreased in the 2018 plan year. So as a percentage of the overall fee, the triple aim incentive has actually gone down since the 2015 plan year. Back in 2017, Providence did refund $468,000 to PEBB for missing one of the service level measures. So there has been payouts for PEBB in the past. The requirement, though, for PEBB or for Providence to measure themselves against is 90,000 members or 70% of total PEBB membership. And I believe PEBB membership within Providence has not hit this at least one of the last few years. So we're still confirming that with Providence, but I believe the requirements have not been met to meet this. One of the things I do want to point out, this slide particular highlights Providence, but I want to say that both Providence and MODA have additional performance incentives in place. Both of them need to meet certain clinical metrics in order to retain additional fees. So Providence, for instance, has about $1.25 million worth of fees at risk for quality and outcome measures. And then MODA places 5% of their fees at risk, or about $400,000 for certain quality and outcome measures. So those are built into the contracts outside of just this triple aim incentive. I just wanted to call that out. Just note that this is not the only incentive that both carriers have in place.
Nick, this is Ollie. I would just mention also that coming out of the last medical RFP, Providence actually proposed these triple aim incentives kind of to put some skin in the game. So so that obviously was appreciated, and it's been a good marker for seeing their performance and performance outcomes.
Yep. Okay. So next slide, Rose. So a little bit of background before we get into the benchmarking itself. We included the slide because I personally think it's really helpful to look at when you're thinking about, okay, how much we pay a self-insured carrier, what is sort of the variables that go into what we pay. So really there are 4 buckets, starting on the top left, the enrollment. Generally speaking, the more lives that are covered under a carrier, the lower the fee. Each carrier has a certain amount of fixed costs, just like any business. So the more enrollment you have to spread those costs out, typically that drives down a lower ASO fee. Moving down to the bottom left, family size actually has the opposite effect. So for larger dependent ratios, so the more members you have enrolled in the plan, generally speaking, the higher the ASO fee. And this is simply because the ASO fee is on a per employee basis. So as you have more members or dependents, the per employee cost actually goes up because, again, you're covering more lives on the plan. Top right is the vendor. Obviously, different vendors have different costs associated with running their programs. So that's why, obviously, for instance, we have the MOTA fee different than the Providence fee. It's just a different cost structure for each vendor, and each vendor will have slightly different ASO fees. And then bottom right is the plan type. So generally speaking, HMO or exclusive provider organizations, EPOs, have higher costs than traditional PPOs or traditional, indemnity plans, for instance. One of the things in the middle there that I do want to call out is competitive marketing. So obviously we're talking about, the next couple of years here having a medical RFP. We do find that competitive marketing does result in lower ASO fees just from the marketing aspect of things rather than a standard renewal. Okay, slide 13. So here's the benchmarking. And this slide has a lot of actually information to digest. It looks relatively simple, but we try to include some different perspectives on this slide. So starting with the horizontal lines going across the chart, those are the fees for MOTA, Providence, Choice, and statewide. So MOTA is the top pinkish red one. The dark blue is the Choice plan, and the light blue is the statewide plan. Then what we do across the bottom is we're able to slice our data into different data cuts. So we have enough respondents where we're able to, select employers that have greater than 15,000 employees, for instance. Select employers that have done a marketing recently versus those who just do a normal renewal. So what we wanted to do here is just show the sort of the range and how the fees sort of change depending on what data cut you select within our survey data. So comparison one is what Mercer would feel would be the best comparison to PEBB, the most similar. So high employee count and then high member ratio. So more dependence on the plan. So you can see there with that vertical line, the green square is the median, and then we show the 75th percentile at the top and then the 25th percentile at the bottom. So you can see that the statewide plan, the ASO fee, falls slightly below where our median would be, but both the Choice and MOTA plan are slightly higher. Again, not too much higher than the 75th percentile, but still a little bit outside the range there. Comparisons 2 and 3, so those middle two vertical columns there, remove the large group filter. So we're looking at all groups now. And then we're talking about normal renewal versus competitive marketing. So you can see there that the competitive marketing actually does have an effect on the ASO fees. They typically say between, at least in our survey, 10 to 15% on average between when we filter on competitive marketing versus a normal renewal. And then finally, on the far right-hand side, comparison 4 is a high member ratio. So this is, again, what PEBB has with a lot of dependents enrolled on the plan. You can see that the fees for that are slightly higher.
And Nick, when you say the competitive marketing comparison 3, is that when plans are going out for renewal with a large RFP? Is that what's driving it?
That's exactly right. An RFP situation. Yep.
Yeah, Nick, this is Michael. I just want to say, so it's not a renewal, it's actually a new RFP as opposed to just renewing the existing contractor. So a formal RFP would be issued, you go out for competitive bid, and you typically get lower costs.
So this is Sean. Just to clarify here, I'm not actually suggesting this, but just for example, are there organizations that actually do a new RFP contract every year? Every year? I mean, is that a thing? It seems to me like you would. Yeah. Is that a,
I would not say that's a thing, Sean. I think
Yeah.
what we're capturing here, at least in comparison 3, is for it just happenstance that those employers typically every 3 to 4 years would go out to bid, and that's what comparison 3 is capturing, is those select
okay.
employers.
Yeah.
Yep.
Okay.
Yeah,
That
I concur. That's about every 3 years, Sean, is the rule of thumb that that employers will go out for bid.
Okay. And just a reminder, when was the last time we did the big RFP?
It was for the 2015 plan year.
Okay.
Yep.
Thanks.
So then 2013 or 2014,
It would have been 2013 probably. Yeah.
so 8 years ago.
Okay. Okay.
All right, so in the interest of time, I'm going to get to the last few slides here. So Rose, if you could go to the next one. So the other component are the variable fees. So both Providence and Moda do have certain variable fees that they charge as a percentage of savings. Mostly what we're not concerned, but mostly the most prominent. They do have some external network fees for claims basically outside of their core service area. Moda is the same way. There are some out of network negotiations that they partake in, that both of them partake in. If we go to slide 15 to get to the actual numbers, so both Providence and Moda do have lower variable fees compared to our benchmarks. Moda in particular is much lower than our benchmarks. So we've broken out the bar charts between the network fees and sort of the claims management aspects of network fees, again, out of network shared savings programs, et cetera. Claims management is more of the hospital audits, the quality bill pay audits and things like that, financial accuracy, where they may find some error and then they charge a percentage of those savings. So both Providence and Moda do have lower variable fees. And I just want to note, as part of this upcoming renewal, I think this is for the 2018 plan year, we're requesting additional information based on the latest finding. And that's something that we're going, or the latest plan year. So that's something we are going to look at each year now as part of the renewal cycle to make sure we're appropriately capturing these fees.
And go ahead, Siobhan. Sorry.
Oh, I was just going to ask, so if I'm understanding this correctly, then it's the fixed administrative fees that are above the benchmarks. And that's what we should be paying more attention to. And the variable fees are not as high.
Yep, that's correct, Siobhan. Yeah, the variable fees are actually very low. These are very good variable fees as far as, especially in comparison to our benchmark. It's not an issue for PEBB as it is for some of our other clients with other medical carriers.
And Nick, I'm sorry if I missed this. This is a lot of really good information. Do you have a sense of how, like, the volume, the amount of variable fees that we have compared to a benchmark? Is that what this is saying, or is this chart really saying among the variable fees that we do have, they tend to be cheaper? Like, can you help? Do you have a sense for that?
Yeah, this does account for the volume. So essentially what that, take Providence, for instance, that $5.15, we basically divided their total volume of variable fees divided by the total enrollment. So it is capturing the volume of those variable fees. It's not of the variable fees, it's the total volume.
I guess what I'm saying is part of the strategy here to push for more variable fees in more places or less? You know what I mean? Like what, or neither, or that's contractually out of our hands anyway. You know, I'm trying to get my arms around that.
Yeah, yeah, and I'm going to give you a wishy-washy answer as well because
Yeah.
very important, but also there are some value to these programs. I mean, if a member goes to an out-of-network provider and the carrier negotiates from the billed charge to some lesser amount, the provider will always, accept the billed charge or the lower amount, so that's good for PEB, but also won't balance bill the member in that case either because they're accepting a lower charge. So there's two benefits to that. The issue is that sometimes that lower charge that the carrier negotiates is still higher than what they would have otherwise paid because most of the time out of network charges are based on a % of reasonable and customary. So that's why there's a little bit of disconnect. It's good for the member because they're not being balance billed, but from the plan's perspective, it may not be beneficial for some of these negotiations to actually take place. So it's kind of a mixed bag, Sean.
I'm surprised to hear that there's a sort of a mixed bag, confusing billing issue in health insurance. News to me. Okay, good to know. But I mean, yeah, I mean, this is good information. I won't dwell here. We just, I recall this whole topic. I'm kind of hearing Representative Greenlick in the back of my mind. That whole eternal debate about the value of self-insured plans versus fully insured plans. You know, it's kind of on them to control their costs and whatever, get the best deal. And self-insured, it's on you, and you're counting on an administrator to represent your best interests. And the financial incentives to do that really has a lot to do with what you were talking about a few minutes ago about our contractual performance metrics and that sort of thing, and being transparent about billing and kind of active administration versus basically a bill processing system. We have these higher expectations. So this is a kind of a key moment of our consideration for our expectations. So yeah, thanks for going over all this.
And I will say, both Providence and Moda, I mean, obviously their fees are higher than what we would consider benchmarks, but Michael is going to get into some additional clinical programs that they provide over and above what we normally see with our other clients. So this is not just a fee comparison. They do quite a bit of other things as well. So I'll turn it over to Michael.
Yeah, I just was going to mention a couple things, Sean and Nick. I think another way to think about this, Sean, too, is with a fully insured plan, usually the plan makes the decisions about how to save money, and that could be at the expense, frankly, of member abrasion. You go out of network, we're only paying 50% or whatever of the bill charges for an out-of-network provider, and doesn't necessarily focus on negotiating with that out-of-network provider. So they kind of get to come up with the rules. In a self-funded plan, the plan sponsor, in this case PEBB, gets to decide how they want to design the plan, and then the administrator administers it. So requires then the plan sponsor to be explicit about their expectations, I think, around how they want the plan to operate. So anyway, I think that aligns with what you were saying, Sean.
Yep, thank you.
Mm-hmm. So we can go to the next slide. So this is just a friendly reminder in terms of care management or clinical management programs. These are programs typically at the health plan administrator level. what their focus is, but also actually even provider-based care management programs. What are we trying to do? So we're trying to increase preventive care and primary care, that may or may not be obvious, adherence to chronic care guidelines, and when appropriate, home health and hospice services for people who are in recovery in home health or people who have a terminal illness and getting them engaged in hospice. And we want to see decreases in inpatient admissions, readmissions, hospital days, readmissions. So really avoiding, whenever possible, the high costs of urgent care, emergency department visits, hospitalizations, while focusing efforts on connecting people to primary care and getting preventive care services. So just want to make sure that we all understand that with clinical management or care management programs, it's a focus of not just decreasing every health service, but actually a mix of increasing some and decreasing others. Go to the next slide. And this is another way to think about value. It's a formula really about quality and cost. You know, how good are the services, and how much are you paying for those services? And PEBB does have, as Nick was mentioning, a variety of different clinical quality measures in place to take a look at that. And you just now saw a bunch of cost or pricing information as well. So you have to balance this quality versus the cost, obviously, in determining what you want to pay for and what the value is to you and your membership. Go to the next slide. It's a little bit of a busy slide, but I'll let you read it and I'll talk through it. So we actually had Providence and MODA answer a series of questions around their clinical management programs and their provider network. And so apologies to Providence and MODA that I boiled it down to just a couple of slides, because they really did a very comprehensive job in responding to our questions. So you can see with clinical management programs, usually with a very loosely managed PPO program, the focus is really more of a reactive response, that you wait for the high cost claimants to hit. You do outreach at that time. It's usually an RN registered nurse model with some support from physicians, not much from other disciplines like pharmacy or dietitian or so forth. The staffing is one registered nurse to 20 or 30,000, could be 50,000 people, which means less interactions with fewer members. And then the focus is about 0.5%, at the high end would be 1% of the population in a given year would have any interaction from a case manager. Whereas an enhanced program, the triggers would be sooner, you're targeting a bigger percentage of the population, staffing level is higher, and you have a multidisciplinary team in place. So RN, pharmacist, dietitian, physician, behavioral health, really important, and so forth. So what you're seeing here is both Providence and MODA basically are telling us that they are much more in line with the enhanced model, which is why you're likely paying more money for those services as opposed to the traditional model. So they have multidisciplinary teams. They're doing outreach to a greater percentage of the population. They're engaging more of the population. They're both using the patient activation measure, which is out of OHSU, which is a valid and reliable tool to not only detect patient activation, but there's a correlation to health service utilization costs. So if you're able to increase motivation with the patient or member as you work with them through clinical management programs, you actually can see a decrease in health service utilization and costs. So they both have very specialized programs in place. So pretty robust, actually, clinical management programs, particularly in comparison to traditional programs. I will also say that probably in the last, I'd say 8 years, there's been a growing awareness on the part of plan sponsors that the traditional clinical management programs are, frankly, lackluster. And to Sean's point, particularly for self-funded plans, unless the administrator is specifically told, this is what we expect in terms of clinical management programs, that you get involved at $50,000 level, that you have active engagement of X% of your entire population, you have multidisciplinary teams, you're going to get the traditional model. So some of the administrators are now quickly developing these enhanced care clinical management programs, much like MODA and Province have done. So they're all kind of scrambling to say, we can do this as well. So that, excuse me, that would be my presentation on these two aspects. So again, thanks to Providence and MODA for answering all my questions. This is just a summary of what they told us. Was there a question?
So, Mike, Siobhan, I think you might also have a question. Do you?
I do.
Go ahead.
Oh, so my question, I just wanted to clarify, because you were saying earlier that it's the administrative fees that are higher, and those aren't the ones that have fees at risk, right? Those are the fixed fees. And so my question is around, like with the enhanced programs, are those areas we should be looking at that maybe some of the administrative, we should be focusing in on why the administrative fees are higher. Is that right? And are these enhanced aspects things that go into the fixed administrative costs, or are they things that should be variable based on how well the plans are doing these services?
Go ahead.
So Siobhan, these type of programs are included in the fixed cost of what you pay, essentially, to both Providence and MODA. One of the things is we wanted to give both of the carriers the opportunity, as Michael said, to respond to our benchmarking, and as part of that, as part of why you're paying more in comparison to benchmarks is exactly what Michael's mentioning as far as their enhanced clinical programs for both carriers. These are included in the fixed cost of what you pay for both carriers, and each carrier does have performance incentives related to quality and outcome measures. So each carrier, I think, is measured on a total of 19 clinical quality measures. And essentially, if they meet certain thresholds out of those 19, they retain a certain amount of their fees at risk. Things like adolescent child visits, emergency department utilization, immunizations, cancer screenings, all sorts of different buckets that we work with and staff has worked with over the years, that each program or each carrier is essentially measured on.
So I would also say, Siobhan, that we are in the midst of working with OHA leadership around performance guarantees. And what I see with self-funded plan administration is probably 4 buckets of PGs. The clinical quality is one which you already have. Actually, frankly, we have a pretty robust program around clinical quality, I would say, compared to other groups that I look at. The other would be financial trend, although I think Providence does have one of their PGs around trend or.
That's correct. Yep.
But there's probably opportunity to further expand that, because you can look at unit price trend as well as overall price. Now I'm going to get out of my wheelhouse here because I'm not an actuary, but the other one I would say would be account management satisfaction would be another bucket. And then last but not least would be the clinical management program. So this could be things like timeliness of prior authorization, engagement rates of high cost claimants, which would have to be clearly defined, because there's not you have to clearly define what you mean by active engagement and so forth. And so we're going to be working with staff around how we can, or if and how PEBB can expand that beyond the clinical quality measures, which those are really important. But are there some other categories of PGs that might be relevant and for your population in light of your fees that you're paying?
Okay, thank you.
Yep. Sean?
Yeah, so this is kind of a larger meta question, and I understand, like, it may be a rhetorical question, recognizing that. But so I think that there's this overall theory that a lot of leaders in Oregon have, which is kind of the underpinning of the AAA, which is that if you actively treat, if you actively engage potentially high risk folks, that you get paid off, like there's a return on investment of that, those higher services, in that their disease progression is slower and less severe over time. And so you end up having better health, lower costs at the same time. I think that there's, over time, there's some reality check to that doesn't always pan out. But this is a good example. So, we have this kind of enhanced, I'm hearing you say that Providence and Moda kind of have a more enhanced engagement with disease management with our members, but that costs more. In other words, it doesn't yield savings, perhaps. Instead, it's like you pay more, you get better health, but you don't get lower costs necessarily. You just get better health. So I'm wondering if you have a short reaction to that, or if from your point of view it does pay off in some ways in other places, or if you just kind of want to comment to that, understanding that we could talk about that probably for 3 or 4 days. So I'm not asking for like a dissertation on it, but I'm just just sort of your gut reaction to that, and how it relates to these fees, these higher fees, like higher performance costs more. What are your thoughts?
If I could just jump in really quick, this is Ollie. I just want to remind the board that some of the programs around chronic disease management, like diabetes prevention, really better health, better choices, have been actual board requests to the carriers to implement a program that addresses these chronic diseases. So I mean, it's not all captured. It's not all offered by Providence and Moda's own program administration. I think some of this is things that the boards have actually put in renewal letters over the years.
Several comments. So I actually could, if you're interested, John, come back with a presentation I have about high cost claimants. So high cost claimants are really, I would say, at least 2 buckets. One is the progression of chronic diseases, and just to be blunt, an example of that would be someone with diabetes who ends up being requiring amputation. Or also with preventive screenings, things like colorectal screening, if you detect it early enough that you can avoid more expensive services and procedures. Those definitely have a cost savings to them. The challenge is that it takes time. It's not necessarily in 1 year. And you probably know better than I do, things like tobacco cessation, it takes several years to realize the cost savings. But for chronic disease and preventive services, there's definitely cost savings. It's just not maybe realized in 1 year. The other bucket of cases and high cost claimants are situations where they are not predictable. So someone, I had a colleague who fell off a ladder at home and became a paraplegic. And there was nothing you could do from a preventive standpoint to prevent that from happening. But what you can do is have early engagement with that high cost claimant to help navigate through the healthcare system so that they seamlessly, if you would, and timely navigate from acute care to maybe acute rehab to nursing home to home and home healthcare. There can be savings from that as well, maybe in the range of 10 to 15%. But what it requires is active engagement with that member that has had a unpredictable accident, which is why we have insurance, right? One of the reasons. There can be cost impact. So the other thing I would say in terms of return on investment for care management is there is not a standard definition of that. And I think in order to realize whether you are getting an ROI from any clinical management program, you need to define how that ROI is calculated. And so colleagues like Nick and others would help, and in conjunction with me, help define what that ROI would mean. So 2 buckets: people with chronic diseases or people with preventive services. With early intervention, you can avoid costly health service, and the other would be unpredictable and but then having early intervention to achieve ROI and better outcomes.
So Nick, are we totally, these are excellent questions, but are we totally getting into your next time slot?
Yeah, I think if we could just finish, Michael, in the next couple minutes, I think that would help. I'll do my best, Kimberly, to keep us to that 11:35 deadline for a break, though.
Okay.
I don't.
Well, I don't want to stop engagement because I love these
Yeah,
are
right.
excellent questions. It always seems like we just don't give you guys enough time on the agenda. So, okay, thank you.
We can go to the next slide. So the other area that we talked about was provider network management. And again, here we have traditional versus enhanced. And traditional, of course, is fee for service. So the unintended consequences of that is higher volume results in more revenue for providers. I'm not casting aspersions in providers, it's just the nature of the reimbursement methodology. The credentialing process is usually licensing and board certification, and usually in a traditional model, providers wait for a member to come to them as opposed to more proactive outreach. So in an enhanced provider network model, you have additional reimbursement for providers based on clinical quality, which both of these programs do. The credentialing is not just licensing and board certification, but do they hold the patient-centered primary care home certification, and what are their outcomes? They would be taking a look at that. The migration from value-based care arrangements from paying for reporting all the way to upside and downside risk, and then ultimately total cost of care models. So you can see here that Providence and MODA both have strategies in place around data sharing, value-based care reimbursement models, the incentives for the quality measures, and the credentialing based not only on just do they still have a license and board certification, but what have their outcomes been, and do they continue to hold the patient-centered primary care home certification. You see also Providence disseminates evidence-based clinical guidelines. That's not typically done in a traditional model, particularly for the national carriers. It would just be too lengthy, and providers likely would not pay attention if they were bombarded with clinical guidelines from major carriers. So you can go, unless there's any question, we can go to the next slide, which is our recommendations. So here, what we're recommending is quarterly reporting on the clinical, financial, member experience outcomes, on the clinical management programs, updates on quality improvement projects to improve the impact and effectiveness of their clinical programs, provide definition around what is engagement, particularly with high-cost claimants. Again, there is not standardized understanding in the industry around what that means. And for the next medical RFP, incorporating requirements around staffing, benchmarks, goals, reporting, and so forth that are explicit in the medical RFP. I think there's opportunities there. Similarly, for the provider network management, quarterly updates on key metrics for those providers, particularly that are PCPCH certified, any quality improvement projects. And I think also, I think clinical quality measures more is not better. It may be that you want to focus your clinical measures. You might want to change your benchmarks. You might want to retire certain clinical measures if they've achieved them consistently. Let's focus on something else. I think I would also recommend in taking a look at the clinical quality measures from a DEI lens, from a health equity lens, of are there certain prioritized populations that we should be focusing on to support that health equity strategy that you all focused on. And then again, including specific requirements in the next medical RFP around all these topics around provider quality, behavioral health integration, and so forth. So that's it for my portion of the presentation, if there are any questions. Okay. Back to you, Nick.
Okay. So I just want to check in with Ollie and Rose regarding screen sharing. I know, Rose, you may have been having some issues earlier, but it seems like those have been resolved. Let me know, though, if I'm happy to share my screen for the next utilization report if needed.
Yeah, Nick, could you share your screen?
Yeah, absolutely. Yep.
Okay, thank you.
Okay. Can everyone see that?
I'm not seeing anything.
Okay, let me.
Now I do.
Oh, perfect. Okay, excellent. Okay, so I'm managing two screens here, so bear with me if there's some difficulties here. So the utilization report. So this is the next portion, and I know you know, originally had 90 minutes, but that was good conversation in the last presentation. So I'll try to keep it to our 11:35 stop time so everyone can get their break on time. But you know, again, if there's any further discussion, we can handle that as it comes. So for the utilization report, this is the first report where we actually have data through incurred claims data through June of this past year, June 2020. So we'll be able to take a look, and as part of this report, we've taken a look at how utilization has been affected by the COVID-19 pandemic. So we have a few new exhibits, but we also have mixed in some of the prior exhibits that we've historically presented. We take a look at the trend components, so where the trends are increasing, what service categories those trends are coming from, and then different clinical analyses that we put together. And then we'll end it with some opportunities and next steps. Okay. So data and assumptions. So again, this is the first time we'll be able to actually take a look at the utilization impact of COVID-19. The current period, we have incurred claims July 2019 through June of 2020. And then obviously the time periods progress 12 months prior. So in most cases, we were able to take a look at 36 months of data and compare those trends over time. The self-insured plans are the statewide choice and MOTA plans. Fully insured is now just Kaiser, as all care no longer appears in our information anymore. Just want to point out the caveats down in the bottom right. We do have Kaiser integrated care fees. So these are additional fees that PEBB pays Kaiser that are not included in any of the reports from our data warehouse. So just keep that in mind. There are some additional fees, 19.4 million in the current period of additional costs for Kaiser that is not included in these reporting or in this reporting. Okay. So COVID-19 impacts and updates. So this is information taken from our sister company, Oliver Wyman, who does a lot of really good data visualization as far as COVID-19. The left-hand side of the page is Oregon-specific information, and this was as of last week when I pulled this information. So as of last week, the total confirmed cases across all of Oregon was about 128,000. I did look on OHA's website this morning, and it has been upticked a little bit to 131,000 confirmed cases. Overall, this represents about 5.6% of Oregon's population, which is well below the national average. And the national average is actually higher at about 18.7% of positive COVID or the total confirmed cases as a percentage of the population. And then specifically, when you look at Oregon in that bottom right, that graph shows the weekly change. So obviously the red, it's kind of small, but the red counties are the ones that have experienced the highest weekly change week over week. And so those are Lake, Grant, Union, and Sherman counties all saw growth over 100%. Now that said, I mean those counties, as we know, don't have big population centers, so cases can really drive a percentage higher if there's only one or two more cases. But it's just important to know that where they're kind of from a percentage standpoint increasing. You can see that in the Tri-County area, Multnomah, Washington, and Clackamas counties, those are more of the moderate growth or even slight decreases. Multnomah in particular has had a slight decrease in cases. So with regard to PEBB, so this is where we're looking at PEBB-specific COVID information. So we included a number of figures on the top half of the page, and then the bottom half of the page looks at your per employee per month medical costs. So you can see obviously in the March, April, and May timeframes that costs and claims were much lower than historically we've seen. Across all of your self-funded plans, there have been 31,000 tests administered. This is about 0.27 tests per member, per 1,000 members, excuse me. So that's and it has increased obviously in the last few months compared to when we looked at this. I think we saw these figures in the August timeframe. For PEBB, we have about a 3% positive test rate, and that's 1/3 of the national average. So nationally, we're seeing about 9 to 10% of the tests come back as positive. For PEBB, it's about 3%. 4.2% of COVID cases have been admitted to the hospital for PEBB, and that's about half of what we would expect based on PEBB's demographics. So we have some internal tools that are able to calculate the probability of whether you'd be hospitalized from COVID. And so 4.2% is actually lower than where we would predict based on PEBB's demographics. And then on the bottom row there's about $4.8 million worth of medical costs associated with COVID treatment through November. And so that's in line with current infection and admission rates. And then that big number in the middle there, that's 78 million. So that's what we estimate is the impact of the delayed or canceled medical care through October. So we anticipate the surplus. Again, we talked about the risk-based capital reporting last month and how the surplus has grown over the course of 2020. And that's mostly driven by the delayed care, the canceled care that we experienced as a result of the COVID-19 pandemic. And then finally, on the bottom right or the middle right, we estimate in 2021 there's likely going to be about a 2 to 3% impact for care returning to the system, but also the vaccine administration when the vaccine becomes rolling out to the general public. We anticipate administrative costs related to that vaccine of around 0.5%. So obviously the doses themselves are covered under Operation Warp Speed from the federal government, but the actual cost to administer those in an office setting, in a Walgreens or CVS, there's certain costs to administer the vaccine. So we anticipate those costs will increase PEBB's overall expenditures in 2021 slightly in comparison to where we would otherwise predict them to be. So now we take a look at the actual utilization from COVID-19. So there's a lot going on this page, but we wanted to provide a overview of what's actually happening. So the top left shows various screening rates for cervical cancer, colon cancer, mammogram, and then PSA, which is prostate cancer. So you can see the screening rates were all, relatively speaking, between 2 to 5% or so prior to the pandemic. But then as we got into the March, April, and May timeframe, those screening rates declined drastically as fewer people were actually going into the provider's office and fewer labs were being administered. In the latest month we have incurred claims for, in June, you can see that mammogram in particular jumped back up to around 4% screening rate, which is around historical average. But the other ones have, especially the cervical cancer and the colon cancer, those have not returned to their pre-pandemic levels, at least in the data we have. It very well could have done it later in Q3 or even Q4, but we did not see that in the June reporting that we have. And then the bar charts on this page show the incremental monthly increase in newly diagnosed patients for various conditions. So the top right are asthma patients per 1,000 members. And with each of these charts, the blue represents 2019 data and the red represents 2020 data. So you can see, and then that black line in between there is the percent change. So the black line refers to the right axis. So the right axis is the percent change, and then the left is the actual newly diagnosed patients per 1,000 members. So you can see that in the May and June timeframe for asthma in particular, we saw less newly diagnosed patients, 41% drop in May, about a 12% drop in June for newly diagnosed asthma patients. In the bottom left, the diabetes newly diagnosed patients, we actually saw a larger drop in the April timeframe. April, May, and June. June actually saw an uptick, but April and May in particular, we saw 43 and 32% drop in newly diagnosed diabetes patients. And then similar for hypertension, it actually followed a similar track as diabetes did. Hypertension patients newly diagnosed actually decreased about 35% compared to last year for April and May. So certainly there was a drop in patients being diagnosed for these various chronic conditions in the springtime. Now, in the June and July timeframe, at least for diabetes and hypertension, those trends sort of reverse themselves. You can see that in 2020, the red line does exceed the blue line. So there were more newly diagnosed patients than what we saw in 2019, but it certainly wasn't enough to catch us up to where we were.
Can I ask a quick question? This is Kate Nass. Without seeing March for 2020, is it fair to assume that we were a little above 2019, or where were we on these three graphs, the asthma, diabetes, and hypertension graphs? In March, was it also similar to 19? And this is I'm missing the kind of baseline.
Yeah, we have the March data, Kate. So I don't know it. I don't know it off the top of my head, but I think it was similar, and that's why we wanted to show the April timeframe, because the shutdowns started to take effect sort of in that mid-March timeframe. So we wouldn't see the utilization drop until the April incurred claims. But I can get back to you on that one.
Yeah, no, that'd be. I was just curious. So this is what you expected because of the shutdowns or the non-elective pause, for lack of a better term in my brain right now. Okay, cool. Thank you.
This is Mark. I have a question about actually going back one more slide.
Sure.
That the fact that the PEBB population had such a lower percentage positive test rate is good news, obviously. I suspect it's because state employees were probably more able to do work remotely, as we're meeting today remotely, and maybe than maybe the average population. So I think that percentage, I guess that's the 3% you might expect, just because so many state jobs are computer based and things that could be done remotely. But the 4.2, that one seems to me to be indicative of people using preventive measures and really being careful, because that's not directly connected to remote working conditions. Or am I wrong?
The 4.2 is really of those positive tests. Which ones were admitted to the hospital?
Oh, I see.
So I don't think, Mark, that would be necessarily. I think that's unfortunately, for lack of a better term, luck of the draw, so to speak. But I would completely agree, and the 3% is in comparison 1/3 of our national positive test rate. As we saw in the previous slide too, Oregon, although all of this is bad. Like I'm not trying to make anything better than it is, but certainly Oregon has had more strict guidelines than certainly some other states. And so the fact that we have a positive test rate of 3% maybe isn't a shock either. But to your point, I think it speaks to the ability of people to work from home, socially distance, and whatnot, and just be safer.
Well, I guess we don't have that on this slide, but Oregon as a state is lower than the national average, but I'm assuming it's higher than 3%.
It is. Yeah, it is.
So PEBB has had lower incidence than the general Oregon population as well.
Mm-hmm.
Okay.
Yep,
thank you.
That's true. Yep. Okay. The next two slides deal with telemedicine. So obviously the big piece of good that has come out of the pandemic as far as utilization goes, telemedicine. People are just generally more comfortable doing e-visits with their providers than they otherwise were. And on the flip side, providers have built out infrastructure now that they otherwise didn't have. I know my provider didn't have telemedicine capabilities or virtual visit, and all of a sudden in the May timeframe, they all of a sudden had it. So there's some build out on the provider side as well to supply these visits, but also obviously the demand has kept pace. So this chart shows the non-mental health telemedicine utilization. The next slide, we do have the mental health and substance abuse telemedicine. You can see that, pretty much January 2018 through February of this past year, 2020, it's remained relatively flat for all your plans. So the top two lines, the green line and the light blue, are the Kaiser HMO and Kaiser deductible. We know that Kaiser just generally has pretty good infrastructure for e-visits and virtual care. So it wasn't surprising to us to see that their utilization has always been higher than the MODA and Providence plans. But then you saw, starting in March, the huge spike in visits per 1,000 members. So actually, for both, or for all three of the self-funded plans, those utilization metrics actually spiked past the Kaiser plans, and it's tough to kind of see. They all kind of get jumbled here on the right-hand side of the page, but those purple and dark blue, and then the choice plan is sort of the teal color. Obviously, we saw huge spikes in comparison.
Hey, Nick, it's Michael. I just wanted to make a point here that this also reflects a fundamental change of telehealth from prior to COVID outside of Kaiser. Telehealth was kind of like an alternative to urgent care to take care of quick problems, usually done by an external vendor like Teladoc, which is the 800-pound gorilla in the in the freestanding telehealth vendors, to actual healthcare providers that you typically see in brick and mortar have now capabilities related to telehealth visits, or actually the broader term would be virtual care, like Nick was alluding to. So e-visits, emailing, instant messaging, text-based, and so forth. So it's really represented a fundamental change for how healthcare providers that have brick and mortar interact with their patient population.
Yeah. Okay, so then the next slide shows mental health and substance abuse related telemedicine visits. You can see an equally larger spike. So we tried to keep between these two slides the scales on the left-hand side of the page the same. So if you're flipping back and forth in the PDF, you can sort of see a visual of how the visits per 1,000 members compare on the mental health side versus non-mental health. You can see obviously the spike is prominent in these type of visits as well, with the self-funded plans, notably MODA, Choice, and statewide, all experiencing larger increases in telemedicine utilization. Kaiser, again, even before the pandemic, had historically higher utilization for telemedicine. The last piece related to COVID, at least in this section, is emergency room visits. So we wanted to take a look at how emergency utilization has been impacted by the pandemic. So the bars, so the green bars on this chart show the emergency room visit count. And so that's actually on the right-hand axis. You can see the visits per month. And then the blue line over the top or overlaying it is what we would consider, what the database would consider would be non-emergent ER visits. So, and the percentage of these visits that would be considered non-emergent. So examples of some non-emergent: body aches, ear infection, migraines, sore throat, minor burns, those sort of things are what the database would classify as non-emergent. So essentially you likely should have been able to seek care at a lower cost or alternative setting, such as urgent care or other form of urgent response rather than the emergency room. What we found is not only a drop in the number of visits to the emergency room in the April, May, and June timeframe, and March for that matter, but also the share of those visits that are non-emergent also decreased. So you can see that the blue line goes anywhere from around 20% to 25%, and it dropped down into the 15 to 20%. So what that told us is not only were people not going to the emergency room, which may or may not be a good thing, right? We want people, if they truly need emergent care, to go there and not feel afraid to go to the emergency room. But what it showed was, for those who did go, those treatments were actually more emergent than what they were or what they had been over the previous 12 months. So the share of those non-emergent visits actually decreased slightly. So possibly it causes people, I know for me personally, I would feel less comfortable going to the emergency room now in a hospital setting than I would prior to the pandemic. And so maybe that slight little pause is what's moving people away for some of these minor non-emergent visits to different settings. Any questions or comments? Okay. All right, moving on. So the next section deals with aggregate costs. So this is where we start looking at what the actual spend has been over the past 36 months. So on the left-hand side of the page, we have 2 years prior, and then we move over to last year or the last 12 months, and then we do the current 12 months on the sort of that middle right column. So you can see that on average, if we look at that middle section of this table, the per employee per year costs, from 2 years prior to 1 year prior, it was about a 3.4% total increase between medical and pharmacy. That has since dropped to a 7% drop between medical and pharmacy. So we went from around $16,300 per employee per year, all the way down to $15,200 per employee per year in aggregate costs. And you can see, obviously, the big drop there is the medical part of that. So medical experienced about a 9.1% drop, and then prescription drugs actually did increase. So we'll talk a little bit about what drove that increase for the pharmacy side of things, but prescription drugs increased about 6.3% per employee per month, which is an increase, but it's actually still at the lower end of Mercer benchmarks of what we're seeing with our other clients. The fully insured plan. So Kaiser was similar story. Kaiser actually had a sharper drop in medical costs. If you look at it on a per employee basis, their medical costs dropped about 14%, and their prescription drug costs increased about 4.6%. So overall, a bigger drop on the medical and a lower increase on the prescription drug. So overall, Kaiser, the fully insured plans, experienced about 11.5% drop in spend in this current period on a per employee basis. And then finally, bringing it all together in this section, the total PEBB cost. So this is both self-insured and fully insured. On a per employee per year basis, medical costs have decreased about 9.9%. That compares to a 3.2% increase that we experienced 1 year prior versus the 2 years prior. And then overall, it's about a 7.8% drop in per employee per month costs. And we'll get into the drivers of what's driving these, but again, this is just kind of the stepping back and looking at the big picture. Mostly obviously due to the COVID pandemic.
Can I ask a quick question? This is Kate again. In the current line, what is the time period?
Yeah, the time period will be incurred claims of July 2019 through June of 2020.
Okay, thank you.
Yep. And Kate, we normally look at this every 6 months. So when we get to the July timeframe, we'll be able to take a look at full calendar years 2020, 2019, and 2018. Yep.
I knew the lag was there. I just couldn't remember if it was 4 or 6. I can't remember.
Right.
Thanks.
Yep.
It's been a while.
Okay. So let's take a look at what's driving those trend components. So we've sort of broken out the trend components into two sections with a little bit different flavor. So this slide looks at sort of the buckets we would consider costs to fall into, whether it be utilization increases, unit cost increases, member health risk, and then cost share and leveraging. In a few slides, we'll get to components of trend that kind of looks at what actual service categories were increasing versus decreasing. So it's a little bit different flavor, or two different flavors. So the total annual increase or decrease in this current period rather was 6.2%. So the blue line represents the current year. The purple line represents the prior year. Obviously, the utilization was the biggest driver. So utilization going down resulted in about a 4.9% decrease basically utilization accounted for 4.9 of the 6.2% drop in the trend rate. One of the things that stood out to me was this member health risk category. And we actually saw a drop in the member health risk of about 3.9% compared to the prior year or the prior time period. For those of you who have been on the board a little bit, member health risk is typically one that has always been increasing as demographics, the PEBB population ages, more chronic conditions get introduced to the population. Typically, we see that member health risk not being a driver of a decrease like it is in this current period. But if you think about what a member health risk is, or basically what we look at as far as risk scores go, a big portion of those risk scores is what members are being diagnosed with. And so if we, think about the COVID impact and how we saw lower newly diagnosed patients with asthma, diabetes, hypertension, et cetera, across different chronic conditions, If we're getting lower amounts of new diagnoses for our PEB population, obviously that factors into the risk score calculation of how we're looking at the risk score. So that's, I think, why in this current period here, the member health risk is actually one of the drivers of the decrease, rather than anything inherently different about the PEB population as a whole. I just think we're capturing less utilization for those chronic conditions than we have been in the past.
So, Nick, to put it another way, when we get back to a situation where people are making more regular use of the medical system, we're going to be paying for this one for a few years as we're detecting the chronic conditions that did emerge that we missed during this period due to low member engagement.
Yeah, I would, if I was a betting man, Sean, I would say that. And then there's also the question of the severity on what will happen if, as those cancer screening rates come up, are people now at a higher stage of cancer than what they would have been had they caught it early. So all of that, I think, will factor into the member health risk likely increasing as we move along. Michael, I see. Yeah.
Yeah, I also would say that there are also going to be, I'm not disagreeing with what Sean and Nick just said, but I think there's also a grouping of people who have decided not to have, for example, back surgery or knee surgery. They've decided like that risk is too high and they're never going to have that procedure. There may also be people that develop back pain or knee pain or whatever, that in light of in 2021, in light of the risks inherent in going into a healthcare facility, they will choose not to have surgical procedure, which I don't think is necessarily a bad thing. But I am concerned about the preventive screenings falling off, and I'm particularly concerned, and I know I've said this before, about childhood immunizations falling off. And because parents and are not typically not bringing children into the school where they would be checked for their immunization regimen, we'll see an uptick there as well as children and young people return to school required to get their vaccinations. So we'll see an uptick in that as well.
This is definitely something that we'll talk about in the Ways and Means presentation in a couple of weeks that I'll talk about later. But the bounce back effect, and seeing as how we've had a fund sweep over the last few legislative sessions, the importance of really not putting us at risk by further fund sweep because of the bounce back effect until we have a better idea of what that's going to be. Also, that a big negative on a PEPM basis for our 3.4% test is kind of going to reset the baseline for the following year and be a real challenge to meet that 3.4% the next year.
That's right. Okay. So let's take a look a little bit more at the risk scores by plan this time. So you can see that the purple line is the prior period, so July 2018 through June 2019. The blue line is this current period, which is July 2019 through June of 2020. You can see that the risk scores across all three of the self-funded plans decreased, and then overall PEB is about 4% less risky, so to speak, across these three plans. One of the things is we did exclude Kaiser from this. We have been working with Kaiser and IBM Watson, who is our data warehouse vendor. There's been some issues with the risk scores being captured accurately for the Kaiser population. So we didn't want to muddy the waters here and show Kaiser. We're actively working with, and I know Kaiser is actively working with getting those corrected within IBM. So again, drop across all plans. So let's take a look a little bit, moving out of the sort of different buckets of costs. Let's talk about where people are actually getting their care, or where care actually saw the largest decreases by place of service. So you can see that, facility specialty pharmacy was one of the only drivers of increase. So going back again a few slides to where we looked at the total cost for PEBB, we saw that pharmacy costs were continuing to increase year over year, whereas medical costs were all lower than what we had experienced in the prior period. And really the driver for those pharmacy costs was specialty pharmacy, specifically within the facility setting. There are 3 drugs that are really driving the increase here. So Humira, which treats arthritis and skin disorders; Stelara, which treats arthritis and then plaque psoriasis; and then finally Enbrel, which treats rheumatoid arthritis and plaque psoriasis. So what we found is those 3 drugs were really the drivers of why specialty pharmacy in particular had that 8% bump in comparison to the prior period. The other categories, at least on this slide: outpatient surgery down 17%, inpatient costs were down about 9%, and then physician office visits, unsurprisingly, was down about 26%. So that physician office visits does not include the telehealth spike. So there was some slight uptick, obviously, in the telehealth utilization and costs associated with telehealth utilization. But because telehealth overall is a little bit less expensive, what we found in the data, telehealth is less expensive than actual in-person office visits. The uptick in telehealth was not enough to overtake that drop of 26% for actual in-person office visits. In chart form, so this is by service category. So this shows a few more buckets outside of just the main drivers we saw on the previous slide. The most significant service category, again, is that facility specialty pharmacy costs. You can see really that's the only one on the that's appearing in the red markings on this slide. You can see the inpatient, outpatient, emergency room, and physician office visits all were green, indicating that they were actually driving lower per member per year medical costs, or pharmacy costs for that matter, compared to the prior period. And then one thing, I mean, obviously, radiology and lab, right? Those experienced a decrease as well. And it's, I think about myself, if I'm not going into the provider office, there's no chance for them to subsequently order additional lab work as well. If it's just a telehealth visit, unless they send me to a standalone lab facility, or they, the doctor says, yeah, I need to go get labs, I feel like there's less chance for folks to get those lab work done as associated with a normal provider office visit. So that's kind of why we see lower lab and radiology being completed.
So Nick, if I could just make a quick side note here, that this is not for something to just peel apart right here, but this is turning into something of kind of an annual tradition, which is about pharmacy, and really having some time, whether it's in an actual board meeting or some other format, where we can have a little dialogue with our legislative partners, and I don't know, maybe a little aside here with Representative Salinas, but there's a role for the federal government to play, because the future of pharmacy is so scary in relation to just sustainable healthcare cost growth. I mean, it is terrifying, and so there's a role for the federal government to play. There is a role for the state government to play legislatively, and then there's a role for the plans to play, our role, and then there's a role for the for the insurers. I mean, for PEBB to play, and then there's a role for the the actual health care system, the plans to play. And really being able, not at this moment, but being able to detail out who's responsible, like what can you do at those different levels? And what are we doing at those different levels in order to have a productive conversation with our legislative partners? Because I know that the legislative branch is equally interested as a whole in those cost containments, because ultimately PEB costs are really facing down these pharmacies, and there's only so much you can do at our level. There really is. So although that's not to say we can't do anything, but it's a team sport. So anyway, I just want to put that plug in, Ali. I cannot remember at this moment how many slides we had in the legislative update that are just kind of like, hey, pharmacy, by the way, we should talk about that. But it's definitely, I guess I'm calling for a kind of an invitation here to have some dialogue with our partners, especially in the legislative branch, so just around this topic. That's it.
One thing I'll just say to that, Sean, is I think both Providence and MOTA on the self-insured side have expressed willingness and interest to partner in whatever legislation or purchasing that may be required either at a state level or to the extent we need to at federal level. This is something that that is certainly not unique to PEB, obviously. Providence and MOTA, for their part, are doing everything right as far as checking the boxes go, as far as site of service programs, getting the step therapies and all the utilization management that we can possibly have. But at the end of the day, it's likely more of a unit cost problem on the pharmacy side than anything else. So yeah, I mean, you're absolutely right. I guess I'm preaching to the choir here that if there is legislative responsibilities that we need to hash out, I think both plans and Kaiser, for that matter, would likely be interested in hearing what we come up with.
And Sean, if I could just respond to that, this is Andrea Salinas. Yes, there will be several different pieces of legislation around bringing down the cost of prescription drugs. Some more, I wouldn't say more aggressive, but hopefully more effective than what we've tried in the past. Some that I just think, are kind of nipping around the edges. But yeah, I do think this is a longer conversation is warranted around this. And as people may know, I'm no longer the House Healthcare Chair, but I do serve as the Vice Chair. But I think this is a good conversation to have with Chair Prusak, as well as the new chair on the Senate side.
Thank you, Representative. We're anxious to be good partners in that. Thanks.
And this is Michael Garrett. I just want to make a point too that there is a cost for non-adherence to, particularly for chronic care medications as well. So I think, Sean, you mentioned like federal, state health systems, the prescriber and the member, and looking at what are the barriers for members for adherence to medically necessary medications. Is it, typically it's financial. So I think that's a really important component as well, that the unit price may not be that high, but there still are financial barriers for adherence.
Okay. So related to the service category utilization, we wanted to pull out or tease out the COVID-19 impact. Again, COVID-19 is obviously the backdrop for a lot of what's happening. So we pulled out utilization per 1,000 members in this chart or in this table for a variety of different service categories. And the one we've highlighted in that purple color is the telemedicine visits. So for and this is actually just taking a look at the first 6 months of 2019 versus the first 6 months of 2020. So the time periods are a little bit different, but overall, telemedicine utilization, we saw a spike of about 620%. So utilization for PEB went up to around 1,500 visits per 1,000 members in that first 6 months of 2020 timeframe, compared to what we saw in the first 6 months of 2019, which was only about 206 members per 1,000 utilizing telehealth services. And then on the right side of the table, I thought it would be a good comparison point to include our book of business. And so this is all employers within our IBM Watson database. You can see that even though the Mercer book of business experienced a higher percent increase in telemedicine utilization, PEB's overall utilization for telemedicine is much higher comparison to where we see other employers falling, which is good news. So all of this is good news. When we looked at PEB specific data, the cost of an office visit, so in-person office visit, was around $215 allowed amount for office visit. That decreased to about $170 for telemedicine services. So there is a cost differential between in-person physical office versus telemedicine. So to the extent that it's appropriate to drive and continue to drive telemedicine utilization, I think it will be beneficial from a cost perspective for PEB, as long as, again, we consider if members are truly getting the same service from a virtual visit as they are in person, and having the tests that they need to have run and everything like that. Just from a sheer cost perspective, it is advantageous to shift to telemedicine. And then, of course, we saw utilization across all service categories drop. One thing I do want to call out, again, we spend a lot of time talking about emergency room visits. So we did see the drop, obviously, that we showed in the COVID section for emergency room visits dropping about 18%. Overall, PEB has lower emergency department utilization than what we see for other clients. So that to me speaks volume of communication strategies that staff and OHA have put forth on emergency departments and carrier partners have done to promote other alternatives to emergency department utilization in comparison to what we see sort of with the rest of our clients. And then finally, just diving in a little bit more to the pharmacy trends. So on this slide, again, there's a lot going on this slide, but in this top sort of left quadrant here, we show overall allowed amount per member per year drug trend. So total drug trend was about 5.2%, but then what we do underneath is break it out into 4 different buckets. So essentially when we look at pharmacy, we look at what drugs are flowing through the prescription benefit manager, or the PBM, versus what drugs are being administered in a medical setting. So provider offices or outpatient settings, or even inpatient for that matter. So that we see there that the specialty drugs flowing through the pharmacy benefit are actually the biggest driver there of 18.5%. So if we look at what the drug drivers are, or the trend drivers are in this bottom section here, we look at the two main culprits here, which are Humira and Stelara. Stelara in particular saw a $1.7 million increase in spend compared to the prior period. So Stelara again treats plaque psoriasis and psoriatic arthritis. Osteoarthritis in general, and is one of PEB's biggest drivers of costs to begin with. So Stelara fits right into that bucket. And there were 108 patients versus 95 in the prior period. One of the things that we've talked about for a number of years, and one of the things that MODA and Providence in particular have put programs in place to address, is site of care steerage and utilization for some of these specialty drugs. So that's when we're trying to shift administration of specialty drugs from a higher cost setting to a lower cost setting, facility, outpatient to provider office, or provider office to at home, where it's safe and effective. One of the things that appear obviously on the specialty drug for both medical professional and medical office, or medical outpatient, is Remicade. So Remicade appears in both categories. The average cost at a facility, so in this far right-hand category, for Remicade is about $8,100. But if you move that to a professional setting, it drops to about $3,900. So again, it's just speaks to the importance of the programs that the board has put in place and your carrier partners have also put in place. Again, trying to chip away at whatever we can to try and steer drugs to the appropriate site of care is obviously beneficial and important, especially, you know, in the Remicade example. It's just one example of this happening. Okay. All right, just in the interest of time, I want to move on to the clinical top conditions. So this slide lists the top 5 conditions and the spend associated with those conditions. I will say I wouldn't pay as much attention to the numbers themselves as far as the drops or the percentage drops. I think what there actually could be happening, especially in the pregnancy case, the database grouper that we use through our data warehouse partner, IBM, may not be fully capturing all the pregnancy-related episodes associated, given that we only have 6 months of this first upcoming plan, or this plan year. What I'd rather pay attention to is just what these conditions are: pregnancy, diabetes, osteoarthritis, lower back disorder, and depression. Those top 5 are the top 5 in this current period, and they have been the top 5, you know, last year and the prior period before that. So if we're thinking about programs to address clinical top conditions, our recommendation, and I think, you know, PMAC and other folks would agree that these are sort of the top 5 that we have to look at addressing and trying to lower costs within. This slide gets into the top clinical conditions based on the number of patients. So TP1, TP2, and TP3, that's just short for time period 3 is this current period, period 2 is the prior period, and then TP1 is the period 2 years prior. And then we wanted to compare that to the Mercer Book of Business benchmarks. So we have the percentages outlined there as how PEBB compares to our Book of Business. One thing that you'll see is mental health disorders, so anxiety, bipolar disorder, and depression. For PEBB in particular, they're actually much higher as far as prevalence goes compared to our Book of Business. But I will say that this really isn't necessarily a bad thing. It could be the case, and it likely is the case, that across our other clients and nationally, of course, we do have shortage of mental health care providers, and generally speaking, there's probably less access to care than what PEBB has for your members. So having a higher level of anxiety, bipolar, depression, sure, there could be a higher prevalence than the general population, but I think more likely it's actually your members are actually just able to seek the care they need above and beyond what we see in our Book of Business. So I would consider that more of a driver than anything else. And then musculoskeletal is the other category that stands out. So osteoarthritis and lower back disorders are both, for PEBB at least, higher than our Book of Business norms. Our osteoarthritis is about 13.9% higher, and then lower back disorders are about 36% higher as far as the prevalence goes. So this shows the number of patients per 1,000 members.
Hey, Nick, just a couple comments. One is, I think, access to mental health, I don't know about PEBB, but has increased as a result of telehealth and COVID. So there's a number of behavioral health digital solutions available to people. And we've seen across the country huge uptick in use of those services as a result of COVID and people not feeling comfortable going in person. Which I think having a behavioral health background is not a bad thing. Musculoskeletal tends to be the largest category for employer-sponsored health plans. right, Nick, with other
Yeah,
clients.
absolutely. Yep.
MSK. And I think also if you just think about this, maybe keep it in your hip pocket, like as we think about centers of excellence or digital health solutions, remembering, and we can help remind you that these are the health conditions that are very prevalent in your population. So I think we want to look at whether it's COE or digital health solutions or what have you, that are addressing these condition or combination, because we know that people with, for example, cardiovascular disease or diabetes also have co-occurring mental health, behavioral health conditions as well. So just a couple of comments there. Thanks.
Okay, so the last few slides in this analysis look at sort of the illness burden. So this slide, the top half is Oregon PEBB specific data. The bottom half is Mercer Book of Business specific data. So many of you have probably heard the old adage, 5% of members drive 50% of costs. It applies across different industries. It's the old Pareto distribution or principle. So for PEBB in particular, the bottom line here is the member distribution. The top is the cost distribution, so the allowed amount. So what we have here is 4.2% of high risk members drive about 38.1% of total costs. If we expand that into the moderate and high, so both the red and yellow categories, we have about 39% of your members driving about 86% of the total claims costs. So this is not really unheard of. You can see that across our book of business, we have about 5% of members driving an even higher share of the claims costs. For PEBB in particular, the green actually makes up a little bit more than the rest of than our book of business. So 50.4% of your members are what we would consider low risk, and I think that also has to do with overall PEBB has more dependent children on the plan, and I think overall dependent children have a relatively lower risk threshold or risk level than adults. But 13.3% of costs are driven by low risk members. And so things like preventive screenings, provider checkups, obviously we have the mandates in place for a number of years now as far as primary care spending. So those type of things actually take a larger share of the overall spend for PEBB versus what we see across the rest of our clients. And then, so what type of categories are within these different risk buckets? So really what we want to do, as Michael sort of alluded to, is target conditions that appear across multiple different risk categories. And so to the extent that we can meet people before they get into a higher risk category is very important. I think the low back disorders or musculoskeletal is the biggest example of these. There are solutions out there that you can do virtual physical therapy now. And it just is an app on your phone, and you can have real consultations and real exercise routines just from your phone to help try to prevent some of the more serious cases down the road. And then if we do need to progress to the red or the high to catastrophic illness burden, as Michael alluded to, we need to have centers of excellence in place to really determine if you're medically fit to proceed down with whatever procedure it is. And if you are selected for that procedure, we want to make sure there are bundled payments in place and there are warranties, and the quality, the clinical quality is up to par with where we'd expect it to be. So really what again we should be looking at is either point solutions or your carrier sponsored programs that prevent people from moving to higher risk categories. And then when they are in those higher risk categories, making sure that they're receiving care that is the highest quality.
Yeah, Nick, I want to emphasize too that that with COEs, the biggest cost savings is from people who are screened out. So they're referred particularly for surgical procedures, And once they go to the COE says, oh, by the way, you don't meet the criteria, and that there's shared decision making so that the member is made aware of conservative alternative treatments, so that surgery is not always the best option, or that the member can actually decide for themselves what makes sense for them based on all the available treatments, whether they're conservative or surgical. And we know from studies that when members are given the options, that they tend to choose the more conservative and less costly and non-surgical interventions.
And just add, the innovation work group this afternoon is going to have a lengthy discussion on centers of excellence and responses from our RFI that we just had sent out.
All right, so last few sections, I know I only have about 9 minutes left. I think we're going to actually be perfect on timing. So low value care. So this is another section or another piece where we have sort of some database tools that we like to explore. Essentially what we're looking at here is antibiotics for respiratory infection. So the reason this may be an issue is that some adults and children with certain things like the common cold or any sort of non-specified upper respiratory infections, who essentially receive an oral antibiotic either on the day of their diagnosis or within 9 days of their diagnosis. We don't, essentially that would be considered low value care. Most upper respiratory infections, at least in the ambulatory setting, are viral, and subsequently they don't actually respond to antibiotics. Not only that, antibiotics will have other side effects that may contribute to development of more resistance to those antibiotics within the general community. So what we want to see on this is as close to no prescriptions administered for respiratory infections as possible, especially because a lot of that time we don't think it's actually an effective treatment for upper respiratory infections. So the top chart shows the adults, and then the bottom chart shows the children, broken out by the various plans. And then the left column is 2020, and the right column is 2019. And so you can see that for all the plans, there was actually a lower prevalence of antibiotics prescribed across their different provider groups shown up in the database. So all plans did show improvement in lowering the rate of antibiotics prescribed for these upper respiratory infections across both adults and children. And then the other two are arthroscopic knee surgeries and then the vitamin D screening rates. So the top chart shows arthroscopic surgeries for knee osteoarthritis, and specifically it shows the percentage of patients with a diagnosis of generalized or localized osteoarthritis who have a knee arthroscopy within basically a year of the last diagnoses. So across all the plans, once again, there was a decrease in arthroscopic surgery for knee osteoarthritis. Now, this one in particular, I think, could have some COVID effects being thrown in there. As we know, a lot of care was either deferred, delayed, or canceled. As Michael said, some of the procedures for lower back disorders and musculoskeletal, people likely realize maybe I don't need a knee surgery, or maybe I don't need a back surgery or a spine or hip or whatever it may be. So part of that, I think, is actually due to the pandemic and people probably just not being able to schedule some of these surgeries. But overall, all plans showed improvement in these arthroscopic knee surgeries. Likewise, for vitamin D screenings, all plans showed improvement in the percentage of patients who don't have a medical condition, but who get vitamin D screenings. So essentially for vitamin D, most deficiencies really don't have a high risk conditions, and so it's not really advisable to screen for it. So all plans showed improvement in the screening rates for vitamin D.
Nick, are you talking like bone density tests or for the vitamin D?
Actually, that's a good question, Kimberly. I'm not actually sure what goes into a vitamin D screening. Michael, I don't know if I don't know if you're aware.
Bone density is a separate thing, Kimberly, than vitamin D screening. I would also say, I don't know whether you said this, Nick, but these low value services use the framework from Choosing Wisely, which is a nonprofit that gathers information from medical societies and associations and how they define low value. So it's not Nick or me or
This is not Nick Albert's definition of low value care.
Yeah. Nick didn't get a medical degree in the last few months. So, and so just so you know that's what we're basing it on. And so Choosing Wisely, which is available to providers or members for that matter, gathers this information again from medical societies and associations.
Really?
Value.
Thank you, Michael. Yep. Okay, so I'll move on to our opportunities and next steps and sort of areas for improvement. Some of these are items that we're, again, sort of already on the track with the plans to address, or they've already began addressing a lot of these. The first one is related to metabolic and cardiovascular. Obviously, we know we have quite a bit of spend in metabolic and cardiovascular conditions. Our recommendations would be for clinical program review for each medical carrier to ensure the effectiveness. And I think this also, a lot of these go back to the conversation we had earlier with the administrative fee benchmarking. And essentially, what we know your carriers are doing more of an enhanced clinical model than what we normally see with our clients, but it's actually diving into the results of those clinical programs and making sure that they're effective, especially in relation to some of these top drivers of claims that PEBB has. The other one for metabolic and cardiovascular that we would say is just the promotion of your existing carrier programs to address some of these issues. Obviously, RFP would be sort of a last step option, and I know that is down the road anyways. For musculoskeletal, I think, I already alluded to this. It's keeping people in a lower risk spectrum than otherwise. So trying to prevent people from going to moderate to high, or even preventing people from going to low risk to moderate risk. And so we do that by promotion of the carrier weight loss programs, back care programs, massage and physical therapy benefits. So I think it was for the 2020 plan year, we added the massage therapy benefit for the alternative care program. So, we're, as part of the renewal, actually, we're going to be looking at utilization of that program to see how many members have been utilizing it and if we need to adjust that benefit at all. So that's one thing for musculoskeletal, is promoting those sort of lower cost settings before they have to get to where we even need a center of excellence. Mental health is the third bucket. Again, as Michael said, the promotion and use of teletherapy is really important. Teletherapy has obviously shown to increase the level of access that people can have. So it's again, just promotion of that. Continued communication to steer members to available resources, obviously including the EAP. I know the EAP program for PEBB is actually very well utilized. Cascade Centers does a really nice job of administering that program, and they have a lot of good resources for employees. So it's, again, trying to steer members as needed to the EAP program. The fourth one is almost a COVID-specific one for the non-claimants and the deferred care. So obviously we saw the screening rates decrease. We saw as Michael has expressed his concern with childhood immunizations. So for the deferred care, we want to make sure that the plans and staff are communicating to members about the importance of preventive visits, screenings, virtual care, all of those aspects that help people to get into the provider and feel comfortable with doing so, right, in the midst of a pandemic. Even though the vaccine is, well, fingers crossed, relatively soon in the grand scheme of things, but making sure people get the appropriate care they need. And then finally, the low value services we just went over. The plans already do a certain extent the educational strategies with providers. I know the plans work with their providers to address some of these low value cares. It's just continuing to push them to make sure that they are addressing low value care with their in-network providers. One of the things that we have on the docket for this plan year is to conduct a clinical assessment of the carriers and plans. So we will have colleagues. Michael, I think, will be leading the charge on a clinical assessment, but that's one area where we can actually do an audit/assessment of the carriers' plans and the programs clinically, and get a report out to the board on those. So those are our top opportunities for improvement based on what we saw in the utilization report. I'm 1 minute over, but I'll ask if anyone has questions or comments.
I think the group is pretty good about asking their questions while you're speaking. So let's go ahead. We're going to honor, and we're going to have a 10-minute break. So we will be back at 11:46. And please don't hang up. Just turn your cameras off or that kind of thing. And please stand up, get a stretch, and we will be back in 10. Thank you so much, Nick.
Thank you.
How's beautiful Seattle,
Michael, do you want to share your own slides?
Okay, so where is the button to do that?
At the top of your Teams, or maybe at the bottom, there should be a little box with an arrow in it.
Oh yeah, open share tray.
Yep, that's it. I think it's usually easier for you guys to do this yourself than for us to say next slide to me. And you can pause and go back as you please.
Can you see that?
I can. You might want to open the slideshow and show it that way.
Yep. How's that?
There we go. Perfect. Thank you. Signing off now.
Okay.
All right. It's 11:46. Hopefully folks are getting back. It's always such a quick 10 minutes.
Let me know when you like me to start.
Yeah, I'm seeing things light up, but it looks like people are getting back into back at their desktops.
Okay.
All right, let's go ahead.
Go ahead. Excuse me. So this is Michael Garrett. I'm with Mercer. So I'm here to talk to you about the board retreat that happened in November, where the focus of the board retreat was really around designing the entire strategy for PEBB around health equity. So here's just some information about who attended from both PEBB and OHA as well as Mercer. We got feedback, which were really helpful to get that. And we had this in 3 phases. One was about the background. The second phase was around health equity. And the third was around what the action items were to implement the health equity strategy. So essentially, this is what we're going to talk about today. This is how I organized it. You can read this. Rather than doing here's what we talked about in sequence from the retreat, which was a lot of content, we've tried to organize this around the health equity guiding principles, the obstacles that we identified, the strategic pillars and initiatives, and the ideal future state. So when we went through this, you've seen this many times. This is the display of the triple aim, the governor's strategy for healthcare, OHA's guiding principles, and PEBB's vision. And we see that health equity and social determinants of health are right in the center. And I think Nick had this also in his. So I'm going to go quickly through some of this so I can spend some more time on the strategic pillars that we've identified. So we agreed to adopt this definition of health equity, which was from the OHA Health Equity Committee. PEBB board also agreed that the priority populations identified in the OHA Health Equity Committee, they endorsed that as well and identified potential other populations that we might want to focus on. This just means we don't want to boil the ocean. We want to prioritize where our focus is. And so there you have the prioritized populations. This is a busy slide, but I actually really like it. This is from, again, the Oregon Health Equity Committee. This is the framework to how to think about health equity. I like how the model shows it kind of upstream, meaning what is the environment that you come out of in terms of where you live and work and the challenges you have based on your race, gender, sexual orientation, gender identity, ability status, and so forth, all impact your health status, so that when you actually see your doctor or go to the hospital, that you bring all of that with you. And the PEBB board agreed that this is the framework that they see as well. Oops, sorry. For the PEBB population. The PEBB board also agreed that these 6 key assumptions from the Oregon Health Authority Health Equity Committee were also resonated with them. There was also some discussion around number 4, which is that equity must be intentionally pursued as a strategy. So there was recognition from the board that it doesn't just magically happen, that we have to be intentional about it, and we have to be deliberate about it. Also, might be somewhat controversial, but important to point out that inequities in the population are primarily a result of social and political injustice and not of lifestyles, behaviors, or genes. But I think this is a real good background for understanding the challenges within health equity and the key assumptions. So we identified some obstacles. So one of the challenges with health equity is being able to look at data on the membership. That's how we discover health disparities. So unjust healthcare based on a demographic, for example, race or gender or what have you. So we need to get access to that data. That although that might be a temporary obstacle, I think we need to address it in order to be able to understand where's the population at, where do we need to make improvements in achieving health equity. Another challenge is board and staff time and resources. And so there is a recommendation that a subcommittee be formed in order to do some of the groundwork with OHA staff members and Mercer as your consultants to develop some ideas and suggestions for the board to consider as a whole. Creating and maintaining diverse board composition, again, needing to be intentional about that, looking at how do we get individuals from the prioritized populations as members of the board in order to have that voice present. The capabilities of the carriers and vendors in alignment with current scope of work. So where are the carriers and other benefit vendors at, and how do we affect change if there are opportunities for improvement, and creating and maintaining member communication channels. None of these are impossible. I point these out just because some of the strategies we've come up with are really actually addressing some of these obstacles. So not insurmountable, but things to bear in mind as we try to move forward in really having health equity at the center of your overall strategy. Stop for a second. Are there was someone trying to say something or? No, okay, great. So in thinking through what the board discussed and agreed to in the board retreat, we came up with these health equity strategic pillars. So, and I'm not going to read to you all of that's listed there, thank goodness. But one is understanding that there's a variety of different stakeholders in place, and that there's work to be done. Because remember that health equity has to be intentional; it doesn't just magically happen. And so identifying ways to get the voice of the member from all of the different prioritized populations, key, the board, OHA, elected officials, you can see benefit carriers, vendors, health systems providers and staff, and consultants. So Mercer too, as your consultant, also needs to be held accountable for how can we help in achieving health equity. The second pillar is decision-making based on a health equity lens. So there was really good discussion about this and how do we evaluate both operational and policy decisions from the lens of health equity. And so to that end, we need to develop some kind of tool to help look at decision-making, again, both at the board level policy, but also operational, probably being done at the OHA level of any decision that's being made, and how does it, if it affects health equity, and does it affect it, and then what kind of decision should be made. Also remembering we need to get the voice of the membership in here as well, because they're the ones that will talk to you about from their perspective if certain decisions will impact health equity. Prioritized populations, I already mentioned that's a strategic pillar, and getting representation on the board and, for example, PNAC or the Wellness Council is important so that we have the voice of the prioritized populations at the ready. Health equity metrics. You'll see the recommendation actually will be to not reinvent the wheel, but to use existing metrics and have the advice of the health plan metrics committee around setting what those metrics should be, and looking at standardized measures, monitoring for unintended consequences. In other words, if we focus on this, does something else unwanted happen? And then really focusing on improving equity. And then how do our bridge strategies and long-term strategies support health equity is also important. These now in more detail for folks. So in terms of the stakeholder, that first pillar, members are at the very top. So making sure that we have clear communication channels. We have existing PMAC and the Wellness Coordinating Council. There's also employee resource groups that we could tap into. All of that will need to be designed to figure out how do we potentially integrate the input from the ERGs and from PMAC and the Wellness Council. I will also tell you that in my work in DEI that that it's really important that the ERG, sometimes they're called business resource groups or diversity council, is really important to listen to that voice, not to delegate work to them, but to see them as the sounding board for decision making that you're going to be doing. So that will be really important component. For me, it's the most important, actually. Already talked about board diversification, making policy decisions based on a health equity lens, OHA staff incorporating health equity from an operational perspective, figuring out how we can get the voice of elected officials. So Representative Salinas, you and your colleagues, making sure that we consider them as key stakeholders in this whole process. Benefit carriers and vendors, finding out where they're at in their journey around health equity, what are their strengths, what are their opportunities. Health systems providers and staff, figuring out how they can help identify health disparities and achieve health equity. And Mercer consultants as well. There's a variety of things that we could provide to you, identify best practices we see with other organizations, conducting a DEI, diversity, equity, and inclusion benefit assessment, for example, or other ways of supporting you, for example, with data reporting. I know I'm going through this fast, but I'm just conscious, Kimberly, of my time, making sure there's one more discussion point. Decision-making based on a health equity lens. We have done this work with other clients about essentially what I'm thinking of as like a screening tool to be able to, or like a critical thinking tool to help look at policy and operational decision from that lens. How does this impact, for example, any of the prioritized populations? Is their inherent strategy to address social determinants of health or health disparity? Not that if we say no to any of those doesn't mean you don't do that, but just being really intentional about choices, solutions, decisions that you're making, and is there an impact on health equity for a particular population, more broadly on social determinants of health or health disparities, and prioritizing those decisions and solutions that will help support identifying and addressing health equity issues. Prioritize populations. So we need to work on collecting data fields for demographics, if at all possible. That may need to get some clearance from a regulatory or legal perspective, and then developing and implementing programs to meet certain needs, ensuring that we have representation from the prioritized populations at the board level, PMAC, Wellness Coordinating Committee, and so forth. Making sure that the materials that are available to members are available in different communication channels so that we make accommodation for people with vision loss and hearing loss is really important. And also developing marketing materials and so forth that reflect a diverse population. So making sure that racial and ethnic minorities are represented, or for example, wheelchair users, same-sex couples and families, of all different kinds are included. So that signals to the membership that we are approaching this from an inclusive perspective. Metrics. So what we're suggesting here is the recommendation from the Sustainable Healthcare, I always forget the name, Sustainable Healthcare Growth Target Committee. This is their recommendations, which the board felt were advisable to make sure that that we listen to the input from the Health Plan Quality Metrics Committee regarding their standard set of measures, any unintended consequences, and health equity initiatives. And so on the determining the metrics, we want to make sure that we select preventive services, chronic care services, adults, children. Member experience is really important, obviously, all the way to identifying and addressing low value, which Nick just talked about, and avoiding complications and that higher cost of care. Remembering that slide that I have about with care management, we want to increase preventive services, chronic care services, adherence, and then avoid the costly emergency room and whenever possible, hospitalizations. So this is kind of, will be under construction as I see it for 2021, waiting to see what the Health Plan Quality Metrics Committee, that's a mouthful, and the Health Equity Committee come up with for 2021. So there's some alignment with PEBB with these other initiatives. And the bridge and long-term strategies, I will say that we've already incorporated health equity into, for example, the COE, the Centers of Excellence request for information that just was sent out, and we're going to be hearing about this afternoon from the at the IWG meeting. We inserted questions around how would these solutions, whether they're from their existing carriers or from a vendor, how would they support health equity? So we're already incorporating that, at least in this particular situation. I would also say that there was been at least one study on the impact, for example, of centers of excellence and bundled payment programs on racial and ethnic minority. There's preliminary findings that for some racial minorities, that there is a positive effect actually from COEs and bundled payments. It's one study. I don't want to, get too overly excited, but at least there's one study that showed that actually there was a positive impact. I would suggest that it's because with a COE and a bundle payment program, this was a Medicare COE and bundle payment program, that shared decision making and providing choices to the member were inherently part of that process. So we just have to remember that as PEBB pursues any of the bridge strategies, or certainly the long-term strategy around expanding value-based care.
And Michael, can you share that study with us? Thanks.
Absolutely. Yep. Yeah, Siobhan, yes, I can do that. I shared it with, I'm remembering who I shared it with. I think it was Dana and Jeremy in a prior to the board meeting, but I can absolutely share it. I was really pleasantly surprised, Siobhan. Not surprised. I had a very positive reaction to see that it worked, in terms of supporting health. Okay, so next steps is forming a subcommittee, and gosh, I would love any input.
Yeah, Michael, I can outline that. I can outline that. Ask if it's the right time to do that.
Sure. Yeah. Go ahead.
Okay. Yeah. So what we'd like to do is request a delegation from the board to create a subgroup, likely made up of staff and probably two board members to keep this health equity work moving forward, especially during the 2022 renewals, and report back to the board periodically for updates. If you have any interest in being one of the two board members, you can, please go ahead and contact me. I won't ask in public right now, but otherwise I'll reach out and see if we can get to. And we envision the subgroup working quite closely with PMAC and our Worksite Wellness Council, as Michael discussed earlier in the presentation, really having the member have a strong voice, be at the table. So really, that's it.
Yep. And if it'd be great to get some feedback about these 5 strategic pillars and if that resonates with board members. And you know, Mercers or consultants are certainly willing and able to help draft ideas and thoughts around how to approach some of this. As I mentioned, some of these items are going to be addressed sooner rather than later. Like, for example, the quality metrics, we want to wait and see what the health plan quality metric committee and health equity committee come up with. But some things are sooner. Brian Olson's already been in contact with me to connect me up with PMAC and the Wellness Council, which is great, and exploring also how the employee resource groups, and there's several of them, that they might have some input and communication also with PMAC and the Wellness Council. Like, let's leverage what's already in existence to get that voice of the member. And then we can put together a project plan with timelines and accountabilities.
Sounds great.
And just to keep front and center that this is what we're trying to achieve, which is from the Healthier Together Oregon Health Equity Vision.
And Ali,
Go ahead.
I just had a quick question. Ali, were you looking for any kind of formal agreement from us about having the subcommittee? Because I know we discussed it at the board retreat.
Yeah, I think, you know, the board retreat kind of gave direction to create a subgroup, but I guess I'm more confirming that if anybody has any issues with that. So I don't think they need formal action being taken.
I mean, that was my understanding from the retreat, that this was something we needed to do to move this work
Right.
forward.
Yep.
And Siobhan, not to put you on the spot, but I'm just curious, or Kimberly or whoever, like, do you feel like this reflects what we talked about at the board retreat?
Yes. I do, yes.
Okay, good. Okay, good. I just want to make sure I'm not off track or saying something that misrepresented. I want to make sure I'm aligned with what your thinking is. The difficult part was coming up with those 5 pillars, and once we thought about it, it's like that seems to make the most sense. They're all integrated, but it seemed to be that's kind of where we landed. So good. Well, thank you. So Ali, people should let you know if they're willing and able to participate, and it can be more than 2 people. And we also thought about the subcommittee could also have participation, right, from PMAC or the Wellness Council or ERGs, you know, actual members could also participate, right?
Yeah, absolutely. We'll come up with a kind of a plan, and we have to be careful with the number of board members, but but I've already heard from one, so so we're well on our way.
Great. Well, that's it for me today. There's appendix, but I don't need to go through that. It's in your materials. But
Thank you, Michael. Did anybody have any questions for Michael? Looks like we're heading in the right direction. I appreciate everybody being so engaged. I think we need to, this is something that we've absolutely got to keep as part of our work, is around the health equity, and we're not trying to get into the innovation work groups work. We're not trying to get into anybody's, we're trying to help align with them, is really the work that I see us doing. Okay, so it looks like we are ready for Ali, for director's update.
Thanks, Kimberly. Just wanted to give everybody an update on the extension of the no-cost COVID testing and treatment. It's been extended to March 31st of 2021, which is what we're hoping for. And vaccinations are also fully covered for our members and their dependents. believe Nick mentioned earlier, there's an administrative charge that we'll get on the back end, but that wouldn't impact our members. We've actually started getting really involved with the vaccination task force, especially in the areas of distribution and payment. This has mostly been on the OEB side, as educators are part of the next priority group, as you probably read or watched on the news. As more vaccination providers are approved and more vaccinations are actually received, we should hopefully start getting to the bulk of PEBB members, by late spring, early summer. We're hoping. PEBB has actually had several employees in the 1A priority group from agencies like Department of Corrections, Oregon Youth Authority, and our state hospital. I'll pass along any further information as it becomes available. We met with Department of Education and Department of Administrative Services last week, and we have a pretty significant statewide network of agencies, school districts, universities, community colleges, people that are used to setting up flu shot clinics for their institution that we can leverage. Again, it's just getting that approved provider and the vaccines, but things are starting to really pick up steam, so that's encouraging. Also, the legislative session has started, and hundreds of bills have already been dropped, and several of those have, a somewhat significant impact on PEBB. We're still making our way through that big pile, but we'll have a more significant update at the next board meeting. And then early, I think around February 9th, Kimberly and myself and the OEB board chair, Jeff Brown, will be presenting to the Ways and Means Subcommittee, and we'll pass along that presentation once it has been delivered and update you on the questions that were asked. And that's all I had.
Thank you, Aldi. Rose, did we have any public comments?
No public comment.
I just want to thank everybody that joined us today. There's a lot of a lot of visitors on the line. There's 44 of us in this Teams meeting, and I want to thank you all for taking the time out of your day to join us for the PEBB board meeting, and appreciate the work that you're all doing out there. We're not done with COVID, and we need to get rest and keep strong and keep really taking care of all those different populations that we serve. And so I appreciate you all being here, and I appreciate the providers, and keep taking care of our members. They're very important to us. Does anybody else have anything before we close today's meeting? Looks like we are adjourned, and thank you all very much. Innovation Work Group is later this afternoon, so we'll see some of you there. Take care.
Thank you.